national standards that have been set by WHO. We have people in our midst who are vexed in quality, so they will walk us through our quality journey. But before that, with a round of applause, let's invite the CEO of the Trust Hospital to give us her opening remarks.
Thank you very much. In fact, Louisa took the words out of my mouth. If you had asked me, that is what I would have said. A combination of everything everybody has said. So, fellow management team members, unit heads, esteemed staff, ladies and gentlemen, good morning. Today marks World Quality Day, and so we gather here to celebrate not just a commitment to quality, but a journey marked by dedication, resilience, and an unwavering pursuit of excellence. This year's theme, From Compliance to Performance, is both a challenge and a celebration of how far we've come and where we need to go as an institution. So quality is a journey, it's not a destination, and it's about continuously raising the bar and creating an environment where excellence isn't just a goal, but a way of life. At the Trust Hospital, our quality journey has been transformative, with substantial milestones that highlight our commitment to being a healthcare leader in Ghana. One of our significant strides has been the establishment of rigorous quality structures to guide our path forward. We have set up a robust risk management framework to help us proactively identify, assess, and mitigate risk, thereby creating a safer environment for both patients and staff. Our annual staff and client satisfaction surveys have also been valuable tools, giving us insights into areas we can improve and ensuring that our workplace is supportive, engaged, and driven by a shared commitment to excellence. We've also invested in the professional development of our staff as well, with 50 of our team members now enrolled or who have been enrolled and have completed the training at the IHI Open School. And this training has equipped our staff with cutting-edge skills and knowledge that are directly transferable to the quality of care we provide here every day. So I'm proud to say that we are raising a team of quality champions who will drive this hospital into the future of healthcare. Compliance has been an essential foundation for our quality journey. We are guided by internationally recognized standards such as Safe Care and regulated by bodies such as HIFRA, Atomic Energy, and the Ministry of Food and Agriculture, and no, that's not ministry, that's mortuary and mortuary facilities regulatory authority. So these standards are not just checklists, but they are scientifically proven frameworks that ensure timeliness, efficiency, effectiveness, and most importantly, patient safety. And they serve as benchmarks and pillars that protect us and provide direction for international standards of quality. So some people in the crowd said that, you know, we are working according to standards set by accredited regulatory bodies, and these are a few of them. However, our goal is not just to meet these standards, but to go beyond them, to transform compliance into performance, okay? So compliance means we are meeting the standards, but performance means we are elevating them in everything that we do. So moving from compliance to performance means ensuring that every process, every patient interaction, and every decision reflects our commitment to quality and the best possible outcomes for those we serve. To be truly high performing, we need to embody these standards in our day-to-day work and embrace the changes, education, and protocols that come with them. So a lot of us feel that suddenly there are so many SOPs, there are so many protocols, there are so many things, there are so many rules, there are so many regulations, but that is the future of healthcare. And healthcare now measures everything, because what you cannot measure, you cannot improve. And so we should be ready to have even more protocols and guidelines and checklists and so on and so forth to guide whatever it is to do. So we are not just passing audits, and we are not just creating checklists. We are building a culture where quality is the heartbeat of our hospital. By achieving this, the Trust Hospital will not just meet global standards, but we will set them. Setting the benchmark for healthcare excellence in Ghana. So once again, thank you all for your hard work, commitment, and unwavering dedication. With your help, and together, we will achieve our vision and become a model of quality, performance, and care. Thank you very much.
Thank you, Madam CEO. We are going to receive 3 presentations, and these presentations or these departments play a paramount role in quality. And these are going to come from the other department, the health informatics, and then the quality team. So the first presentation we are going to take from the health informatics. The theme of their presentation is the role of data in the delivery of quality healthcare. It will be presented by Mr. Bright Kodia. Please let's welcome him.
Hello. Good morning. All right, so as has been said, my name is Bright Kodia, and I'm doing this presentation on behalf of the Health Informatics team. All right, so we've been given the task to make a case for data in the quality equation. And that is exactly what I'm going to be doing that. So my presentation will be taking the outline as follows. So I'll first of all seek to establish the role of data in the healthcare quality delivery. And I'll be doing that on strong 5 foundations. I'll use 5 foundations to justify that. And then after which I'll conclude. Thank you. All right, so globally, across the world, health is built on blocks. And when you look at the WHO framework for health system, which is about 6 blocks. You can see in the health information. So information form the key part of health system, every health system. And so you can see that even amidst all the other building blocks that is needed to be able to have a strong health system, information is key. And obviously you know that information is actually processed data. Before you process your data, you can't have an information. And so the foundational units for information as part of the building blocks of every healthcare system is data. And so data is really key to every health system. And as far as trust is concerned, even when you look at our system, you can see that hospital information system is part of the whole foundation or the building block for Trust Hospital. If you look at the definition by WHO on healthcare quality or quality as far as healthcare is concerned, you can see that it defines healthcare quality as the degree to which services for individuals and population increase the likelihood of health outcomes. And I've underlined 2 keywords there, the degree and then outcomes. The degree signifies a measure, all right? So how can we juxtapose our quality of our services here to standards? So to what extent our services we give at our various points of services conforming to standard? And to be able to justify whether what you are doing is conforming to standards, you need data to be able to do that. All right, so you need to look at your outcomes and see by what extent are your outcomes also conforming to set standards of outcome with respect to your mortalities, all the parameters you are looking at. We should be able to be sure that it is conforming to standards. And you need data to be able to justify this. My next foundation is the Dunamedian model of quality of care. And everybody within the quality space understand the essence of this particular model when it comes to healthcare quality. You know, this model was founded by a Lebanese physician who is by name Dunamedian. And this man specialized in coming up with a framework as to what every healthcare that seeks to embark on a quality agenda must meet. And this foundation or this framework is hinged on 3 major blocks. First of all, this physician indicates that for every healthcare system to thrive, you need 3 things in place. You need a structure, you need a process, and you need an outcome. When you look at the structure refers to all that which can be referred to as input, all the resources you need, the staff you need, the departments, the kind of buildings, the kind of equipment, your supplies, the environment, and all that conforms or comes together to form the structure. And you know very well that to be able to establish the right components of this structure, you need data to be able to justify that. So, as a trust hospital, you need to be able to establish a particular number of staff you need to be able to execute a particular healthcare service. And out of this, you are going to need the output data to be able to establish that you need this particular number of staff to be able to execute this particular activity. Across the world, every staffing norm systems ensures that the output is fused into establishing the needed staff strength for every point of service. And you need data on all your output services to be able to establish this particular ingredient as far as the structure is concerned. When it comes to equipment, the kind of equipment you need to be able to establish that based on the number of services or this type of services you are rendering, these are the equipment you need. So that let's say you have a particular facility, or let's say Trust Main, you have in a month you are recording about 6,000 or 10,000 patients and you only have just one biochemistry machine. then you should predict that there's going to be a lot of pressure on that chemistry machine, and so it is subject to breakdowns, so that that can inform your procurement processes to be able to make amends for these particular structures to be available to be able to execute the function that it ought to function. So the point I'm making here is that even to be able to have a strong structure, you need data to be able to justify that particular structure. When you look at your processes, when a patient walks in, to what extent is the patient enthused about the kind of processes the person has to go through to be able to get to the end product or get to the pharmacy to be able to get medications and go home? So do you have systems where patients come in and they go so quickly? Let's say within 20 minutes at OPD services, patients enter and they're able to go home, or they come to a facility and then they spend like 2 hours, 3 hours to be able to establish, to be able to get whatever service they are in for. And you need to be able to prioritize surveys and all that to be able to establish your waiting time. Then you establish that, okay, I trust our expected waiting time is, let's say, 20 minutes at OPD. And so when a patient comes and the patient is delaying, based on the structure you've set for yourself, based on the processes you have been able to put in place, that you are able to attend to a patient within 20 minutes, you know that you are either conforming to standards or you are not conforming to your own set standards. So that the kind of system you run, even when you look at our system where all our systems are on electronic mediums, you should be able to have a system in place where your internet services are in line, your network connectivities are all good, so that a simple instruction, if a doctor is attending to a patient, the computer screen will not be turning around for a while before the person has access to the patient information to be able to administer whatever service you are supposed to give. And so the point is that in streamlining or in ensuring that you have a strong process in every healthcare system, you need data to be able to justify all these things to be able to build a strong process as far as the Dominion model is concerned. Your outcomes. Basically, your outcomes are, we are looking at the desired expected results. So your deaths, your disease, your disabilities, discomfort and all that. These are the desired outcome whenever every patient enters a healthcare facility. We should be able to establish that these desired outcomes that are experienced within your healthcare space, are they conforming to the expected desired outcomes? What are our mortalities compared to national standards? Are we within or we are out? What are our length of stays? Are we conforming to standards or we are out? What are the satisfaction level of our clients? Are they complaining or they are happy as and when we attend to them? All these particular outcomes, you need data to be able to establish these outcomes to know whether you are building a strong health system or not. And so the point we are making is that in getting a stronger health system, as far as the Donabedian model is concerned, data is the fuel. Data is the fuel to be able to establish these strong systems. My next case, still on making a case for data in the quality healthcare journey. If you look at the aims of healthcare quality, every healthcare quality model has an aim. And if you look at this aim, the aim seeks to make sure that standards are conformed to. So standards set by regulators, standards set by our WHO, the HIFRA, the Ministry of Health and all that. You need to be able to be sure that all the processes you are undertaking within your particular facility is conforming to standards. And these standards were not just set out of the whims. They were set with collection of data over time. And so if we have set standards that our CS rate is supposed to be 15%, it is continuous collection of data over a period to be able to establish that CS rate must meet these particular standards. And so every standard is set with data. You need to prioritize continuous collection of data to be able to set those standards. And so to be able to get these standards in place, data is needed to be able to set those standards. And to be able to also establish that whatever you are doing is conforming to that standard, you also need data to be able to compare what you are doing as against what the standards are. And so data is very key in setting your standards. Quality healthcare, prioritizing gap identification. You need to be able to identify gaps so that you can propose solutions or you can propose improvements. And to be able to identify these gaps, you need to monitor your processes. You need to collectively, systematically collect continuous data to be able to establish these gaps so that even if you are proposing solutions or proposing improvement, you know that your solutions or interventions will help you bridge those gaps. So you need data to be able to do this. Quality, like I indicated earlier, prioritizing prevention. You need to be able to anticipate the issue before it does happen so that your solutions or interventions will be more proactive. So we say it prioritizes prevention of harm other than repair of the harm. And as you are going to take steps to come up with a system that will help you to prevent these harms, you need to have a monitoring system in place. And that monitoring system will definitely involve collection of data over time to be able to establish that particular harm as and when it does happen. You need to be able to do a lot of analytics. So it's not just about collecting data, but after collecting the data, you need to be able to break them down, analyze them to be able to provide insights for action. And so every quality, healthcare quality, in terms of its aims, prioritizes data insight. And in all this, data forms a whole ingredient in establishing all this particular thing. All right, so like I said, quality is more preventive. And so there should be a system in place to be able to collect relevant data. There should be a system in place to be able to aggregate and tabulate that particular data, analyze and interpret, and disseminate. When these things are done, then there will be information available for any action to be taken. So that when we are going leftwise, we know that we are going leftwise because we are justified to go left-right, not just going out of our feelings, so that our actions will be information-driven. And all this is done with data. My next establishment, my next foundation is that I looked at the dimensions of healthcare quality. When you look at dimensions of healthcare quality has about 8 dimensions. But the purpose of this presentation, I'm just going to focus on 5. In all these dimensions, you can see that data is required to be able to establish these dimensions. So first of all, healthcare quality prioritizes safety. So patients must be safe as and when they come to your facility. They should be assured of coming and going home just like how they came. All right, so some of the parameters used in measuring safety in the healthcare space are falls. And so you need to be able to collect data on your falls. When patients are on admission, are they falling? What is contributing to the falling? Is it the beds or those things? So you need data to be able to establish your falls. What are your pressure ulcers? What is the data on your pressure ulcers, your surgical infections, your success rate of surgeries, your medication error, hospital-acquired infection rate? These are all parameters used to establish safety. And you need data to be able to calculate these parameters to be able to establish safety in every healthcare. Timeliness. What is your waiting time? How is your emergency response rate? All these parameters, you need data, continuous collection of data to be able to establish this, whether you are giving interventions timely or not. And data is key in establishing all these. The next is efficiency. How efficient is your system? So in terms of the dimensions of healthcare quality, we focus on efficiency. Efficiency basically refers to using minimal resources to achieve greater impact, all right? And so to be able to establish your efficiency, you should be able to use data to be able to establish whether you're efficient or not. In a healthcare environment, what are some of the parameters to be able to establish efficiency? These are your staffing norms. You should have proper staffing norms, like I said, justified with output data to be able to establish that this particular work require this particular number of staff to be able to execute them or not. What is your occupancy rate? So the number of beds in your hospital, are they being put to good use? So that when if you have a situation where your occupancy rate, let's say 90%, then you know that, hey, the optimum occupancy rate in every health facility should be, let's say, 80%. So it means that I'm prone to no bed syndrome, so that I'll take action. If your occupancy rate, let's say, less than 50% or 50%, then you know that about half of your beds are empty. Meanwhile, you are paying people. You need to be able to intensify your education or your campaigns to be able to get more patients. All right, so these are some of the parameters used in establishing efficiency. Net profit. You need money to be able to run every healthcare. Of course, your length of stay should be between 3 to 7 days, medical care facility. So that, and I can tell you that Trust, we are doing about 3 days, which means we are within standards, right? Yes, so it tells us more about the kind of services we give to our patients, because patients tend to spend more time at the wards when they are not getting better, right? When they are not better, will you discharge them? No. And so if patients are staying too much long at the ward, you should also anticipate that your quality is compromised. You should also anticipate that possibly they are also going to be subject to other risks, like these pressure ulcers and all that. All right, so within Trust, we are also conforming to standards, and I can tell you that our length of stay is around 3. Your mortalities. So yes, definitely mortalities are part of the outcomes in every healthcare space. Nobody wants anybody to die, but death is part of our outcomes. So when a patient walks into our facility, they can go home, or they can be treated and discharged, they can be referred to other level of care, they can be transferred to other specialties within the same facility, or they may end up dying. All right, but in estimating these things, you need data to be able to estimate your mortalities. And I tell you that Trust, our mortality rate is around 1.0, which is better than even national standard as well. So it means that we are conforming to this quality, and we use data to be able to establish these things. Your affordability is one dimension, and you need data to be able to establish all these things. Your medicine availability, the kind of equipment, and all that. These things are all relevant in every healthcare space in establishing access, and you need the data forms key in establishing this. The next, and that is going to be the last foundation, or the 5th foundation upon which I'm establishing the relevance of data in the quality care journey, is that every healthcare quality improvement use tools. So every improvement requires tools, and there are tools in different ways. So there are tools in the gap identification. There are also tools after we have identified the gap and we want to implement an intervention. There's also another tool to also follow. So in terms of the tools for gap identification, we have examples like the brainstorming, the root cause analysis, the 5 whys, the flow charts, the 3 diagrams, the benchmarking. These are all adopted tools, established tools used in identifying gaps in every healthcare improvement. And all these methodologies requires collection of data at some point. And so data is relevant in the using any quality improvement tool to be able to identify gap. In terms of implementation, so let's say you've identified your gap, you have an intervention, you want to close that. There are certain models you have to follow. So you can either choose to do the plan, do, study, adapt, which is popularly known as the PDSA, or you use the lean approach, or the SWOT analysis, or Six Sigma approach, fishbone analysis. Each of these methodologies you are going to adopt in implementing a particular intervention to close a gap will require data collection, data analysis, data interpretation for action. So the point is that in using any quality improvement tool, data is central in all this. Conclusion, as has been said by Madam already, we are a healthcare institution, and the name of the game is evidence, because it's a scientific environment. You know, Madam will say we are not engaging in spiritual exercises here. All right. So once we are in a scientific environment, we need evidence. All right. And evidence is hinged on data. You need data. All right. If you look at Safe Care, when they came to assess us, if you look at their major objective after assessing every facility, they expect that after assessing you, your facility, you'll now be equipped to be able to drive investment. You'll be able to increase patient safety. You'll be able to enhance patient outcomes. You should be able to also foster efficiency. All these expected outcomes of every Safe Care certification are established using data. And if you look at ourselves as we are at level 3, we aim to get to level 5. And when you look at level 5 says that before a facility is accredited as being at level 5, you should be able to become a facility that is regularly monitoring treatment guidelines and standard operating procedures through internal audit. Yes, so I've highlighted monitoring and audits. And so all these particular activities, either you are monitoring, either you are auditing, you need data to be able to do that. So the point we are making basically is that before we get to the level we expect to get to, we should become a healthcare facility that establishes a better system to be able to collect data, analyze that data to inform data-led actions before we can get to our expected journey. And I end by saying that this professor called Professor W.E. Deming is a statistician, and he has his favorite quote, which I believe in that much. He says, "In God we trust, all others must bring data." Thank you.
Thank you so much, Mr. Kodria. The quote is really inspiring. In God we trust, but all others must bring data. We've learned a lot. So in the quality journey, there are so many things that we need to do. However, everything is centered around data. So in our daily work, data, data, data. The next presentation we are going to have is by the head of the audit department. The presentation theme is the role of compliance in the quality healthcare, And we have heard audits talk about a lot of structures they have put in place. Most of the time they'll tell you, you have to invite us to speak to your team. You have to invite the audit department to come and create a risk register and all that. But most of us, we really do not know what's the risk and compliance department, the role they play in quality. So today they are going to talk to us about the quality journey. And like I said, their topic is the role of compliance in the quality healthcare journey. With a round of applause, let's invite Mr. Edu Mensah to come and take over the stage.
Good morning. Sometimes I forget your name. Morris, how are you? You are so useful to us. Thank you. Oh, Paris, I don't want them to see. Let me put it in the presentation mode. Here, here. Wait. Yes, okay. I want it to be in the presentation mode because it's not showing. Will you want to come and help? Okay, come. Okay. So it's in the presentation mode. Thank you. I didn't want them to see my slides because I have about 74 slides that we will go through with your permission. This is compliance. Yeah, so you must comply. Yes. 74 slides. And we will go through systematically. We will get there. It is because you have not been inviting us to your departments. We have compiled everything to make sure we give them to you. Once again, 74 slides. Thank you. So, internal audit, risk, and compliance. The role of compliance in quality health care. This man called Ingalls, Samuel Ingalls, 2022, said that compliance or regulatory compliance is a term used across industries to describe rules and policies that prohibit or regulate specific products, services, or processes. I become worried when I see definitions like this because they make our work difficult. That compliance means prohibition. Big words to scare people. So when they hear the compliance department, they say, you are come to worry us. Don't mind him, I have ignored him. Let's take the second one, which I provided myself. Compliance involves what? Obeying or complying with rules, policies, protocols, regulations, laws, etc. at the organizational level, at the professional level, at the national level, and at the international level. So, at various levels, we have certain things that we should obey. We have certain things that we should comply with. What are these things that we should comply with? We will start with the organizational level. At TTH here, that is our hospital, our organization, what are there to comply with? So, compliance is not just on specific laws that you should by force obey and comply. We break it down at various levels. So in TTH, as we are all workers, what is there for us to comply with? What is there for us to obey? We have protocols. Which people develop these protocols? We develop them ourselves. And once you develop the protocol, you should comply. A typical protocol here concerning stores requisition. If you want to take items from stores, you don't just walk to stores and pick any item at all. You must obey or comply or follow certain processes. Even you that you are filling the item that you want to collect, One of the protocol is that you yourself, you can't approve. So if you are here and you are requesting and you are approving it yourself and going for it, I won't say anything. I wanted to say something, but I won't say anything. So these protocols, it's not only the store's requisition, even in your own technical area. I once went to the lab. No, the doctor said I should go and take my sample. I should go and do some lab. So the lab person just pulled the string and then was looking for my vein. I realized something. She was not wearing gloves. You know, so what is the protocol for sample collection or your processes? So quickly I protested. Unfortunately, the then deputy head of lab was there. I said, Mr. Ama, your staff is not wearing gloves and I'm not comfortable. So, And she called her attention to it. So she had to stop to go for the gloves. You see, coincidentally, when she was drawing the blood, there was a spill. You see. So how safe was I, and how safe was the lab staff? This all border on protocols. So if you are here and you don't know the protocols in your unit or department, please go and look for it. They are there. If you don't have one, too, after this place, go and, should I say, construct one or prepare or any of them would do. Thank you. Then also, so it means TTH has protocols for everything we do. Are you aware we even have protocols for even fetching water from that container, you know, that they place at the OPD? You don't know. We have protocols for that. The protocol is that when you go, just take a cup from that thing, how do you call it? The dispenser. And then you fetch, even the way you fetch it, we have the protocol. You don't let your hand touch where the water is coming from. But what do we see? People with their big bottles. You know, they drink the bottled water, that has become their constant water bottle. They can use it for a week or more. And that's what they used to fetch. The fetching cry, it is not just fetching. They will push the thing. I don't know whether you've seen some before. Yes. They will push the thing to make sure the tip of the pipe goes into the bottled water. Water that you have drank. Bottle that you have put all. You see, and some of them too, when they are drinking, they don't raise it like this. So they make sure the tip of the bottle goes into the mouth. Some even go and, go as far as to the neck of the bottle. You are in a hospital and you decide to spread something. So there are protocols. Everything that we do. Even this place, this conference room, if you want to use this place for a program, there's a protocol. You have to go and see Madam, Mrs. Burial, to see whether the place has been booked already. Sometimes when I'm organizing programs here, I have to chase her or the assistant, Joyce. So there's protocol in everything. No? Have you seen the administration top there? Protocol. Now we are even going to put a door there. So that you don't just get up and be walking around and be going into any room anyhow. They are all protocols. Look out for every protocol. Today I'm telling you. We also have policies. Protocols are steps. I think quality has done a lot on protocols. They are just the steps that you follow, in executing a task, in simple terms. The policies, they are the do's and don'ts of the hospital. Do you know them? Have you seen some before? Sometimes when we go around and we are taking people through the CA, the offenses, they say, hey, this one we have not heard it before, especially one particular offense. They say, we have not heard it before. And when you mention it, everybody say, hey, that offense is called office romance. It constitutes a major offense. But we still do. I see some people. Yes. Our processes and all that. But the last one is what strikes me. Our standard as an organization. What is our standard? Quality, has our standard been defined and clearly communicated to everybody? Standard in healthcare. Are we the Yahoo standard, or we are the UGMC standard, or we are the Kulebu standard, or what? We are nobody's standard. We are Trust standard. Trust Hospital standard. We have our own standards. So if you come to work night shift and a patient is coming to collect his or her drugs and you are asleep and the patient wakes you up and then you decide to open your eyes more and then insult the patient. Why did you wake me up? Do you know where I was? The dream. That dreamland. They come and disorganize me. And the person said that, you have disorganized me. You have disoriented my mind. Is that the standard we are talking about? Compliance and quality care. That is at the organizational level. So let's ask ourselves whether TTH, complies with all protocols, all policies, all processes, and our standards. And for me, all these things should be adequately communicated. We will see later. At the professional level, compliance at the professional level. What does that mean? Most of us belong to a professional body. What does your profession say you should obey? Your profession has ethics. Do you even know those ethics? When was the last time you even visited those ethics to go through and see? Since the last time you finished your exams and you were called to whatever, or you became a professional, have you gone back to check your ethics? Fortunately, some of us, through CPD, will know whether the ethics have been revised or not. Very important. Compliance to your ethics at the professional level. At the professional level, too, we preach professionalism, which TTH has adopted or adapted. Did we adopt or we adapted it? We adopted it. And so it is part of our core values. Yes. Is the definition of TTH professionalism the same as your professional body's professionalism? Compliance. Standards and competence. At the professional level, we have standards. And we have certain competencies you need to meet. That is why CPDs are developed, for you to make sure you remain relevant. If you finish school 20 years ago, please, Things have changed. Even if you finished school 10 years ago, things have changed. Don't think that the degree or whatever qualification you had even 5 years ago is still relevant. Things are changing every day. You need to comply at a professional level. Regulations. Your professional level regulates you, regulates your activities. How are you complying with that? Let's come to the national level. There are policies and standards at the national level. At the national level, we have the drug policy. Willie, we have it there, right? Yes. The drug policy. What does Ghana drug policy say? Does it say that you should keep expired drugs on the shelves? What direction or guidance does the drug policy of Ghana give? Are we complying? And we need to know the content before you can say you are complying or not. And as staff, wherever we find ourselves, let's find out certain things in Ghana that are relevant to our profession and see whether we are complying. At the national level too, there are regulations and there are also state laws. The Labor Act, even the Constitution. And for my people, these laws, they play with it almost every day in the office. You go there and they are discussing. Data Protection Act, all those acts. But you see, back to the policies and the standards at the national level. Currently, as we speak, there's a government policy that came out, I think about a week ago, on dialysis. Free dialysis from 1st December. Whether you believe it or not, it is a policy. It has come. Whether you think it will work or it will not work, it has come. You must comply. And as a private hospital, we should start finding out, and I'm glad CMS has started finding out, our role in this free dialysis. What we are supposed to do. Because, you see, if you are supposed to comply and you don't comply, somebody once, a politician once said, there are so many ways in killing a cat. And don't be the cat, because there are so many ways. Right. So you see that compliance goes beyond your environment. The last one I'll talk about is the international level, at the international level. So at the international level, there are certain standards, certain policies, certain things that also regulate your activity as a company, as a hospital. The WHO standards, the safe care standards and all. I think Bright even mentioned some of them. CEO also mentioned some of them in her introduction. You see, so before you can be fully compliant as an organization or as a professional, you should go through these levels. The organizational level, your professional level, the national level, and the international level. Some even add personal level. As a person, what are your standards in life? As an individual, take the profession aside. Take the organization aside. As an individual, when you are asked to go and procure something, and the price is 5 cedis, do you make it 10 cedis? At your personal level. If you go and take our tea roll As for this stereo every day, I will say it because it goes too much. It gets finished too quickly at general stores. So at your personal level, have you decided that every day or every weekend when you close, your bag will be empty and you go home safely? Or something must find its way inside that bag because it is a Friday and it is a weekend. Okay, let's now see. So those were the preliminaries. I told you 74. How many have we done so far? Were you counting? If you've done 3, okay, so we are left with 71 to go. Okay. Regulatory compliance. As a hospital, this is what compliance helps us. If your facilities are licensed and accredited, you are safe. You are safe because you have met standards. Currently, in the Trust Hospital, we are supposed to renew or continuously renew our HIFRA certificate, our EPA certificate, that's Environmental Protection Agency certificate. Somebody will say, a hospital what have we got to do with the Environmental Protection Agency? Your waste that you generate. You see, even you are sited in a community like this close to private residents. Your activities towards them is very important. I don't want to talk about the morgue. I will suspend it because else it may bring a problem, so I will not talk about that. Yes. How do we dispose of our refuse? Concerns the environment. That is why you must comply with the Environmental Protection Agency Act. And we've been worrying Mrs. Bayo a lot. You see, the requirement is that, I'm telling you the requirement so that you will, let me see, they brought some time. Oh, this even more. I will finish before that. The 70 will come. They say I'm left with 50 minutes, so I have some more time. Okay. So, what was I even saying? You interrupted me, and you have distorted my flow of thought. I said what? Yes. So, you see, the requirement is that in all our facilities, when you enter the OPD, you should see the certificates of all those accreditation. You should see HEFRA certificate. You should see EPA certificate, fire certificate, all the certificates. So we've been chasing her. When we go around and we don't see, we call Mrs. Berry, especially here in Premium. As for Premium, they are doing well. They display them. Thank you. That is the compliance we are talking about. So if you to watch, if they don't display it, tell them it's not only us. Maintaining patient safety and confidentiality. Complying with the Data Protection Act helps in quality healthcare. You deal with patients' data. Please don't talk too much. You talk too much. And this person came here, and this person has got this, and this person. Do you know the auditor is hypertensive? Me hypertensive. Me call a whole hypertensive, but my hypertensive. Okay. So you see, data protection very important. You see, quality improvement, in the area of clinical guidelines follows what? Evidence-based best practices. And Bryce said this. If we comply, that is the result we will get. The patient safety standards to prevent errors and harm. I think this one too, Bryce said it. Quality metrics. Tracking performance indicators such as readmission rates, malaria infection rate, and all those parameters that you can have. Then continuous quality improvement. We are saying that quality improvement is not an event. It is a process. So don't think that after today we have finished. You are calling us for what again? Please, it is continuous. He can come to your place anytime. Me too. In fact, my team too will be inspecting to see whether you are complying. Risk management, we've done a lot. CEO said it. You see, if we are able to comply with the tenets of risk management, effectively identifying risk and mitigating it, it will prevent a lot of errors. It's important. Infection rate will reduce, medication error will reduce, lawsuit will reduce, and stuff. Patient-centered care. Compliance to patient-centered care, respecting the autonomy, the dignity, and confidentiality of the patient. You don't question the patient anyhow. Patient wants information from you. Voluntarily give. They are entitled to it. I think DNMS took us through patient safety. Okay. Cultural competence. Providing care sensitive to diverse backgrounds. It is about time healthcare professionals got to know that it is not every woman who wants a man to examine her. What is our standard? What is our stand on it as Trust Hospital? Especially our Muslim women. They are not comfortable with men examining them. Especially when you have to go beyond. Operational efficiency. Compliance ensures that we bill properly. I'm glad Dr. T is here. And he has strengthened the billing section of the hospital. You make sure you key in everything you use, every process. Very important. Facility maintenance, supply chain management, we must comply. I said that from the beginning. The benefits of compliance: improve patient outcomes, enhance quality and safety. Risk is reduced, and then there's increased efficiency. Our reputation is enhanced. What are some of the challenges of compliance? Complex regulatory. My L and R are not good, so when I mispronounce, forgive me. Complex regulatory landscape. Keeping up with what? Changing regulations. The standards, the laws are always changing. That's why some of the laws, you say amendment. So your department, that's audit, risk, and compliance, is always on the lookout. That's why I tell you that we do a lot of discussion on laws in our offices. Resource constraints allocation. Compliance involves devoting resources. These are all challenges that we are facing. Best practices. We have to establish clear policies. Currently, as we speak, I think there are so many policies we have not documented. Yes, and we need, as a hospital, to bring all the policies together so that we'll be on the same page. Our policies are a bit scattered, and we need to clearly define them, document them, so that it will help. And then provide ongoing training. Ongoing training on compliance will result in voluntary compliance. And this is where the world has gotten to. Nobody should be a policeman chasing somebody to comply. There should be voluntary compliance when the people get to understand the whole concept. Thank you. We are done with the 74. We are done with the 74. Thank you so much.
Wow. We went through 74 slides in 30 minutes. I wanted to do a round of questions, but I think I'll let it wait. So we've gotten to the stage where we take the final presentation by the quality officer. He's going to talk to us on the theme that is how to bring all stakeholders on board for quality improvement. Please, with a round of applause, let's welcome Osofo. Oh, this is Mr. Quality, so please clap well for him.
Good morning once again. And then thank you for coming. I think I'm happy this morning because I was walking downstairs and I saw somebody from surgical ward. And the person said, Mr. Pipra, we've been able to develop 20 SOPs. And right, all your improvement journey will go right because human behavior is so complex. Today they are like this, tomorrow they are like that. So it's very, very difficult. You can be staying with somebody for so many years. The person could be your spouse, but one day you will see a different behavior. So human beings, we are just like that. So I think that the crunch of the issue is that if we are able to bring all stakeholders on board, our quality journey will be very, very successful. But before we go into details, let's look at this one. So I want us to look what we've been able to do this year. So we had some people, Madam said it, completing the IHI course. We also had IHI conference today, which we were there. We had customer care training for all staff, safe care assessment. So they did the first assessment, the report has come. And then we also had training by Safe Care. Then we also had quality training. Now our patient safety team is on board. We have a patient safety team right now, and I believe that most of us, we have reps in there. Then we also had quality teams across all units and facilities. And then now what we are doing is also addressing the gap. We also have our client feedback system and Get Involved, which is about 90% completed. So let's go to Safe Care implementation. So now this is what we are doing. So you can see at the top, you can see HQMT. So all the gaps that Safe Care identified, we are trying to address them one by one. Not only the gaps, but as a matter of fact, we also want to go through all the requirements for Safe Care. Are we together? So what we are doing is that we have shared the tasks to the departmental heads. Let's clap for them. They are doing a good job. Let's clap for them. So we share it to them, and they in turn will share it with their heads of facilities and units. So I believe that some of us, we are part of these teams. We are part of the unit teams and then the facility teams. So when they work on it, sometimes they also give it to the supervisors because it's like that. For example, if you receive an assignment, Dr. Abankwah receives an assignment from the lab, for lab, what she will do is that she will give it to Mr. Ama. Mr. Ama, if the assignment given to Mr. Ama is maybe on hematology, Mr. Ama will look for the hematology people and give that assignment to them. Then the hematology people will work on it. They will send it back to Mr. Ama. Mr. Ama will send it back to Dr. Abankwah. Dr. Bankwa will send it back to HQMT. Are we together? Now, when it gets to HQMT, the implementation is at the facilities. HQMT will also give the assignment which is being worked on, whether it's an SOP, whether it's a picture, whatever it is. It will be sent to the facility heads. One, the facility heads are supposed to upload the evidence or the record onto the SafeCare platform. Number two, they are also supposed to get an electronic file on their computers and keep a copy there. And finally, they are also supposed to print hard copies of them and file them in their quality file. Then now it gets to training. So once we have the document, whether if it's an SOP, if it's a policy, then we also have to train our staff. So that is the cycle that we are going through. So we gave out 169 assignments to our departmental heads, and then they've presented, they've done the assignment, they've presented them. So now what we are doing is implementation. So we have a platform with the heads of units. We have a platform. We put maybe assignment 1. All the documents that we need, we upload it for you. Then we are also supposed to upload it onto SafeCare and then keep copies of them. Then finally, you have to also train your staff. So I think we are doing well. Let's clap for ourselves. Okay, so that is the update. So Mary, this is not part of the time. This is just update. Okay, so now this is the presentation proper. How do we bring all stakeholders on board? So when we talk about stakeholders, we are talking about our patients, we are talking about our shareholders, we are talking about the staff as well, we are talking about cleaners, we are even talking about our suppliers. So all these people, they come together to be the stakeholders. So they are involved in the healthcare. What I want to talk about is something called utopia. I know that most of us we've heard of it. So whenever you want to implement a change, first you have to envisage the kind of change that you want. The kind of heaven that you want to have, maybe in TTH. You want to make changes in TTH. First of all, there should be that concept of imagination. You should be able to imagine, to say that, oh, okay, this is how I want TTH to be. This is how I want the lab to be. This is how I want maybe radiology to be. So first, there should be imagination. So Utopia is a fiction by Thomas More. He is saying that, is it possible that we can create an island where everything is perfect? There is serene atmosphere. I mean, there is no crime, there is no jealousy, there is no envy. Is it possible? So it's a fiction. So that's the question. But although we might say that it's very difficult to create heaven on earth, Thomas More says that you can still do something about it. So start something. Are we together? Because if you don't strive to change, automatically change will come and meet you. So every day change or improvement should be part of your daily activity, that you want to get better, you want to improve. So when you look at, who knows Play-Doh, this thing for kids. Yeah. It was done by Noah McVicker. And then this guy used to work in a cleaning company, so he was able to develop the Play-Doh. So initially, the Play-Doh was being used to clean wallpapers. But now he realized that nothing is happening, the business is going down. So he waited for the business to go down. Then one day, he saw that a teacher was using the same Play-Doh to teach the children in school. Then now he said, yes, I've gotten the idea. I think that instead of producing Play-Doh for cleaning purposes, let me make Play-Doh for school children so that they can play with it. And now Play-Doh is huge. The sort of monies that they make is huge. Because he wanted to change. He wanted to change the focus. He wanted to improve upon the business. So he started to do what? To search. Most of us, we know IBM. IBM is a computer company. So they used to make the giant computers in the olden days. Big computers like maybe this room. But they realized that now more people are doing smaller ones. And then they couldn't be in market again. So they took a giant decision that, okay, if that is the issue, then we need improvement. So what they did was that now they decided more into software. That is why now you can still find IBM on the market. But we shouldn't wait to get there before we improve. As we work, we need to improve every day. And then, like I said, improvement is very difficult. Why? Because human behavior is complex. So somebody, Elizabeth Kubler-Ross, in 1969 developed this model, which I want us to go through briefly. So when you announce a change or you announce an improvement in any organization, normally what happens is that there is a shock. Because, once you announce an improvement, it's very discomforting to certain people. Now people are going to lose their power. Now they think that this is not the new way we do things. We have our own system. We have our culture. And sometimes it's very difficult. So the people, most of the time, will resist. So they have a negative energy. It's as if their morale has gone up, but they are just trying to resist the change. Then number three, there's a lot of anger because they don't want to move with the new wind. So there's a lot of anger. Just like COVID, when COVID came, most of us, we were in a state of denial. We didn't want to accept it. Then now we came to the place of anger and we start to blame other people. We start to blame China and then the world powers. Then we come to the level of bargaining and self-blame. Now we are trying to do trade-offs. Okay, I want to do this. I don't want to do that. I want to join this. I don't want to join that. And finally, we come to a state of depression and confusion. That is the lowest ebb. At this place, some philosophers will say, what you need to do when you want to effect change is that first, you need to unfreeze. You need to unfreeze. You have to scatter the whole system. Then now, you try to cause the change. Because if you don't unfreeze the system, there is already a culture. So you need to disrupt the culture. Then now you come to the place where you effect the change that you want to have. Then now you come back to freeze the system so that you can have a new culture. So at the level of depression and confusion, there is a lot of chaos. But more often than not, after that, we see some kind of acceptance. So in the times of COVID, you could hear the new norm. This is the new norm. You wear your mask, and then now you are moving with the flow. Then now you can see improvement in any change that you are bringing on board. So because of human behavior, sometimes it's very difficult when you want to effect a change. And most people will like to resist change. So let's also look at this model from Prochaska, Theory for Change. So he is saying that there is a first level. What is the first level? Pre-contemplation. You've not thought about it. Yes, you are going down, the business is going down, things are not doing well, patients are complaining, other people are talking, but here, you've not even thought about it to make a change. Then you move to the second level, contemplation. And sometimes, most of us, we get to go to the level of contemplation when we see that now we are not getting the desired results that we are looking for. That is number one. Number two, sometimes you cannot resist change. The whole world is changing. Now the whole world is changing from YAM phone to Android smartphone. So you can still be there. You better adapt or you go into extension. So we start to contemplate, what do we want to do? What can I do? So this is brainstorming. This is brainstorming. And brainstorming is very important when you want to effect a change. Why? Because the power of the brainstorming or the meditation determines how fast you can go. Because when you do good brainstorming or contemplation, you are able to even to anticipate the things which will happen in the future. So after contemplation, you do your preparation. Now you implement whatever change that you want to bring on board. Then you go to maintenance. Let me say this. I think that maintenance is very difficult. Maintenance, how to maintain a change, is very difficult. And then when you come to the maintenance level, let me say, maintenance gives you an idea of the people. Like, okay, so let me take maybe CEO. Maybe there is a change. CEO wants to know how effective the managers are working. It will be evident in maintenance. Because the people who are down there are the people who are supposed to maintain the change. Because the CEO is up there, CEO cannot make sure that all the departments, they are conforming. No, it wouldn't work like that. But the managers are supposed to make sure that whatever change is being effected is being maintained at that level. In the same way, if the head of department wants to know whether the heads of units are working, it depends on how they maintain this culture of change whenever change is effected. And then in the same way, if the head of department wants to know how the people down there are working, the supervisors are working, it depends on how we maintain change. Because operations are always down there. That is why in quality they say that normally change should even come from the grassroots because they are working there. And at the moment they agree to effect a change there and it's being supported, it becomes very fruitful because operations, that is where normally we do changes. Are we together? Then the last one is relapse. If we are not able to maintain the system, definitely we go back into our behavior. We go back into our old behavior. So that is the relapse. So we have resistance to change. Why is that? People do not want to change. The first one is fear of uncertainty. We don't know where we are going. I don't know what will happen tomorrow, so I don't want to change. Then the second one is loss of aversion. So this one is a mental issue. So sometimes we are not willing to lose what we have so that we can have something which is better than that. We are just glued to what we already have. So more times we don't want to enter into business, we don't want to take new approaches because we don't want to lose what we have. That is a mental state. Then habit formation. People have developed habits over years, and because of that they want to still maintain where they are. They don't want any improvement, and then they just want to be there. Then emotional attachment. So emotional attachment, the more we stay together, the more we know ourselves. And now if there is a change and we are saying that somebody should move to this place, you see the whole department murmuring. They are not thinking about anything. Why? Because emotionally they are attached to people. So they are resisting the change. Sometimes the person who is even asked to move is not much concerned, but the people around the person, because they like the person, they want to be with the person, they start to agitate. Then lack of control. Sometimes to some people, they believe that assuming maybe I control the whole mother and child, I control specialists. Now you are saying that because of the new change or the new wave, you are taking specialists out of my jurisdiction. Definitely I'll fight it. Maybe I have a personal interest in that, I'll fight it. So lack of control, because we don't want to lose our control. So more often times we resist change. Then groupthink. Some people, they've been together like a team, like a group, and then they think in one way. So sometimes if you want to intrude, it's very difficult. There's a stumbling block. If they go for meeting and one person says something, everybody agrees. That is the group thinking. But these people, more often than not, if you want to bring change, they will resist the change. So how do we bring all stakeholders on board for quality improvement? I think I'm almost done. So one, communication. We need to communicate over and over and over and over. I believe that is the duty of pastors. Pastors are always saying, change your mind, repent, repent. They don't say it one time and leave it. You need to speak it 100 times. Then number two, you should look for multiple channels. Sometimes you can do a video, sometimes it can be a poster, everything about what? Quality improvement. You can do a video, you can do a poster, you can do audio. So we have to use all these channels to communicate to people so that they can change. Then stakeholders engagement. So we need to engage people, we need to speak with people. People who are concerned in our healthcare delivery services, we need to speak to them, we need to give them feedback, we need to brainstorm with them, we need to seek for feedback. I mean, even there's a problem, we should sit together and look at the problem together so that everybody can profile input. Then we also have regular updates, project progress, and changes. Yes, from time to time, I believe that we update people on our quality journey. Every platform, we try to update people so that we all will be on the same page. Then empathy. In as much as you are bringing new change, you have to have empathy for people. You have to look at their challenges. You have to try and sit down with them and also solve their challenges. So on this one, we move to staff empowerment. We need to empower our staff through education. We need to organize sessions like this for our staff. We need to also bring in joy at work so that people will be happy at work. End of year parties. I don't know whether this year we are going to have it, but end of year party, people liked it. And I've also seen that from my experience, people also liked it. Whenever there's a t-shirt and then they don't get, it's an issue. I think that next year we should be printing t-shirts for Quality Month. Well, I thought we were going to clap. And as you clap, she will record it so that next year, if I go, she will give me money. Okay, so we need to empower our staff. Also, we have also something that we call psychological safety. So in psychological safety, people should trust the system that we are building. Any change that you want to bring on board, people should trust the system that you are building. I also talk about motivation. Motivation is also important. So sometimes motivation can be extrinsic, and then you also have intrinsic motivation. But let me say this. If you are starting a project, and then you want to bring people on board, look at people. The first people that you should attract are those people who are looking for intrinsic motivation. Because sometimes the project will take time before it's able to bring you dividends. But from that time, if you have people who are always crying for extrinsic motivation, it will be very difficult for you to sustain the business. But if you get people who are intrinsically motivated, you can use them for some time. When now the business starts to pay dividend or the project starts to pay dividend, now you can bring in more people who are looking for extrinsic motivation. Are we together? Then the other thing is learn how to tell your story. So sometimes we have to tell our story where we started from. I believe that if I want to start that story, we wouldn't live here. But I think that TTH, we have come far in terms of quality improvement. Then I think that Bright has talked a lot about data, so I wouldn't spend more time on it. But the last one, which is very important to me, is what matters to you or what matters to your stakeholders. Listen to me. Everybody has something which matters to him or her. Our shareholders, there is something which matters to them. What are they looking for? Profit. You, what matters to you? Maybe your salary. Me, what matters to me? Maybe intrinsic motivation. But I like the money too, please. So everybody has gotten something which matters to them. That is why sometimes you need to look at the people in your department, the people in your unit, and know what matters to them, and try to use that to bring them on board. Because even in the world of business, if you tell somebody about maybe a deal, a good deal, of course, not a bad deal, a good deal, what they will first ask you is, what will be my portion? What will be my cut? So everybody has something which matters to them. And then I think that we need to unearth these things so that we can bring people on board. Okay, so I like videos. So let's watch this video. I think that most of us, we've seen this video. It's like 1 minute.
You know what's gotta be done. Move it, move it, move it. Hey, you there, pick up the pace. You're falling behind. Come on, let's go. Everyone, pull together. We've got a threat to our hands. You there. Here we go.
Okay, so the end of the video is that it's smarter to work in groups. Are we together? So I believe the first video, you could see those animals. Some were big, some were tall, some were short. They had a lot of differences, but they came together to resist an enemy. Are we together? So it is smarter when we all come on board and work together. So what is the conclusion? So this is the bus, quality bus. I am appealing to you, get on board so that we can get to landing together. Are we together? Let's clap for ourselves.
so much, Mr. Opon. No, Mr. Peprawade. Okay, so we have gotten to a very crucial part of our presentations today. We've heard from three wonderful people. We have a fourth person, however, he's going to join us, plus the three people who had the presentation in front here, and the panel discussion will be led by Dr. Nanama Abankwa. After the panel discussion, after the panel discussion, we'll be given opportunity to ask a few questions on our quality journey. So,
Hey, DJ, Osofo was even trying to preach. Said, listen to me. I said the man has entered into preaching mode. Okay, DJ, it's okay. This year people, they don't like this one. You didn't come for the Survivors Day. You were dancing because of the songs that were played. So we have Mr. Sosu, Mr. Dumensa, Bright, and Mr. Pepra. Oh, Mr. Bright. So basically, you've said a lot of things. We are looking at the role of stakeholders in the quality journey at the Prince Hospital. So my question goes to you first, Mr. Pepra. it's you spoke about the curve and then the various stages. So I keep getting this question that so what's all this quality that we are talking about in TT? And I'm talking about the stuff. What's this quality? Do we really need to do all this at this time? There is so much work, and then there is quality. There is trial, anger, bargaining, depression, acceptance, and problem solving.
Okay, so I think that TTH is doing well. We are all doing well. Because I remember, I think that even when we were there, I was saying it. There was a time we went for DEBA, and then I think I asked, what do you know about quality? I think that there is and then it's not that we are not giving out quality healthcare. I think that most of the time is the documentation and then the SOPs and then the policies. Because even for you to do an assessment, that is a gap assessment. I mean, you've not done any assessment before, you do a gap assessment and you are able to score to get to level 3. It means that you are doing something right. I think what is pulling us back is the documentation and then maybe the policies and then so on, and then the evidence. Because even with SafeCare, I realized that some of the things that they said we did not have, indeed, we had them. But it was dependent on the person that maybe they met at the time of the assessment. So I think that, and I think Mr. Edumensa also said that, we have plenty SOP policies, but it's like the people are not aware of them. So the burden is on us for us to move a little further to the people. Whatever we have to teach them, and then we'll carry on. But I think we are doing well. There's a lot of improvement. Thank you.
So which part of the curve are we?
So,
Of stuff.
okay, so that one I cannot tell.
So
But I think we are making gains. Yeah, we are making a lot of gains. And then it reflects. So I have access to the client feedback. And then it's a testimony that they are giving recommendations to certain people and so on. So I think that we are doing well. Yes, a lot of people are still down there, but we need to carry them little by little. But we are making gains. So in every change, it starts with information. Mm-hmm. Do the people know what you are talking about? Yes, now majority of the people, they know what we are talking about. And then we've been in this journey for like 3 or 4 years. It's not too much years for us. For you to have people to get even the information within 1 to 3 years, I think we are doing very well. And then that is the first stage. So now they should have the knowledge, they should have the information. Now, if they have the information, then now it comes to the level of change. So the staff satisfaction that we did for 2023, so we are in 2024, that we did in 2023, there is a reflection. More people are saying that, okay, things are better as at the time 2023 that we had the client satisfaction. So I think that staff satisfaction, so I think that we are making progress. And it's not a day. So the curve that you see, as human beings, you cannot determine the time for each of them. Sometimes it will take people so many years. But then when they come on board, they will be able to even to do more than the people who just started. So that's human behavior, and sometimes you have to give it a lot of time for it to reflect. Thank you.
Thank you very much. So Bright, so the role of stakeholders. So how impactful has health informatics been in this whole quality journey to TTH?
All right.
Because people also say that they see you health informatics around health informatics. What at all cry do you do? They see you coming and going, coming and going. Eh, what's your role? How are you helping Trust Hospital?
All right, thank you. Yes, so the role of informatics, like we've demonstrated, is key to every healthcare, every health system. Yes, so I would say that for the past 2 years, when informatics started, of course, you need to appreciate where we had come from. And so it is normal to hear that people still are unable to tell exactly what we do, especially because of our work does not involve just, interfacing with clients. We are normally at the back offices and all that. So people don't see us. People may not be seeing us moving around, the daily movement and all that. In the Ghanaian context, what is deemed as hard working at times can be sweating around and moving left, right, and center. But the point is that the outcome or your output is what determines whether you are working or not. So it is normal to hear that kind of sentiment. But then the point we would want to make is that our work does not involve the usual running around. We have to sit down, break the numbers down, do a lot of thinking through to be able to get to the level where we are able to determine what information we can deduce out of this particular situation. And so, because our output informs action, and the action is taken by the people at the top, we are seen to be engaging more with management and the various stakeholders who are in the affairs or in the helms of taking decisions. And that is why I can boldly say that every departmental head or unit head might have seen us before in engaging. Yes. So what I would want to say with respect to how we've been impactful, what I would say is that data is available for decision making now, because if we all agree that we are in a scientific environment and decisions ought to be backed by evidence, in terms of our clinical parameters, in terms of even non-clinical parameters, we are able to come out with information to inform action. And we engage a lot with the various people who are at the point of taking decisions. All right, so generally, what I would say is that in terms of data availability, we are not there as in 100%, but we've crossed about 60% if you want to even lay down with some benchmarks. So before we came, HIFRA expects that, and if you look at the HIFRA Act, Act 829, certain segments of it expect that a facility before it is accredited should be in a situation where it is able to produce data or supply data to higher levels to be able to inform decisions. We've been able to connect all our facilities to a platform which enables us to report our clinical indicators to Ministry of Health, and that is normally known as the DIMS. So now you have all our 9 facilities connected to DIMS. And when you get on DIMS, DIMS provides those standards, as in what data, clinical data or non-clinical data you need to make available to be able to inform decision. So in your quest to fulfill what the DIMS requires, you are able to get data available for decision making. And that is why we are now able to even hold peer performance reviews. And so every facility, half yearly, annually, we are able to meet here to be able to examine our clinical indicators and our parameters to see how we are doing. This data which is used for this presentation are supplied by the informatics unit. We sit down and break down all the processes you go through, and then we make meaning out of this, and then we supply them to our various unit heads to be able to take decisions. Aside the clinical parameters, there's a lot we've been doing. I mean, there's this committee instituted by CEO, Data Validation Committee. Data Validation Committee helps us to be able to, every month, meet our various head of units to be able to even determine where we are falling short in terms of our data gap. and then we make proposals to close them. Before that meeting is held, the informatics unit will definitely come up with a particular gap they might have identified and make a presentation on it, and then we'll brainstorm together, come up with solutions, and then CEO will now affirm those solutions and recommendations, and actions to be taken. We were part of the medical EMR review committee. The EMR review committee started when informatics came into the space, and we got opportunity to be on that committee. We've been able to look at our EMR, our electronic medical records, which is a health rule, to be able to identify all the gaps in terms of data in there. And we've been able to make proposals and recommendations. And those things are some of the things that the vendors are also taking steps to close those gaps. So there's a lot, but these are some of the few things I can say.
Hey,
So
if
you don't need to see us sweating.
If you had said many there, we
Don't need
would
to
not
see us
close
sweating.
today.
But when we sit down quietly, we are doing a
do
lot
your
of
work.
system thinking. Then thank you.
So now you know what health informatics does. So when it comes to quality, one of the things is sometimes quality can be intangible. It's like you can't touch it. So sometimes we are tempted to think that nothing is happening, but the outcome at the end of the day, what comes out is beautiful, and we all get to benefit from it. So I think that is where they also come in. They are doing a lot. So there was this one time that they did this malaria presentation at one of the data validations, and we realized that we were prescribing a lot of anti-malarials for everybody without actually testing. So that alone caused us to revise our thinking. There was training for all doctors, and when we went back to check, it had changed drastically. So those are some of the quality, because we are providing quality to the client. So if the client doesn't need anti-malaria, should you go ahead and prescribe just because the client came with headache and fever? So they do a lot in their quiet corner. So I'll come to Mr. Sosu. So now you are in charge of, you are the acting head of HAS, and you have transport and catering and security and administrators and all that. So how is your staff also contributing to this whole quality agenda? Because sometimes we feel it's only the clinical staff who interface with people who need to be concerned about quality, because then you are concerned about falls and how clean the environment is and all that. But the non-administrative staff, what's also your role? What are you also doing to help us in this quality journey?
All right, thank you very much. If you look at quality, as we went around listening to opinions of or comments of our staff, many of us talked about standards, reaching certain standards. And then we also talked about identifying where gaps exist and then making efforts to bridge those gaps. If you take the non-clinical staff provide a number of services. You can actually categorize this into administrative services. You have facility maintenance services, like we have with the maintenance unit, general services. We can have even data and records as part of the support staff. You mentioned catering, you mentioned laundry and other areas. Now, if we take, for example, laundry, you know, many of the linens that are used on the wards by clinicians will have to pass through laundry processes. And proper processes need to be put in place to ensure that infection prevention is achieved. And infection prevention is one aspect of quality assurance. So if the laundry department is doing all that it has to do, especially when it comes to laundry of linen and providing these to the wards, that also contributes to quality. The environmental services, that is mainly handled by the environmental health and safety person, attending to the sewage, attending to waste management, medical waste, general waste. All of these contribute to the well-being of our clients, our patients, and it also contributes to quality of care that we provide to the various clinical areas. You can also talk about the facility management service that we provide, especially with the general services. The equipment that the clinicians use, if we don't have the general service person attending to the equipment together with the biomedical engineers to make sure they are well calibrated, the standard of quality will also be affected. So we have the biomedical unit, the engineers who make sure that equipment are well calibrated. We have the general services making sure that equipment, machines that are used are working properly. We have even the catering service that ensures that proper diet is provided to the client, and that also contributes to delivery of healthcare quality. So clearly the non-clinical staff also provide a lot of quality assurance initiatives to the clinical staff.
Thank you very much. So I believe that's how come when it was COVID and the president gave us tax relief, the non-clinical staff also got, because we all contribute to the outcomes in hospitals. So surgical unit has produced, surgical ward has produced 20 protocols, and it's commendable, but it doesn't end with the production. It has to be implemented. So as the one in charge of compliance, how are you ensuring that all these various protocols that we are producing in our quality journey, we are actually implementing it? Because when SafeCare comes, they are not just interested in seeing our documents. They are also they do this mystery shopping, and they want to know that what we say we are doing, we are actually doing. So how are you ensuring that TTH is big, 9 facilities, so compliance?
Thank you. So in terms of monitoring compliance, we have a schedule in our department, and we have schedule officers. That is how come I'm able to talk about practical issues anytime I'm delivering on issues on compliance. So we interact a lot with, especially the heads of units, and even the staff themselves. And sometimes we call for these protocols to study them ourselves. Sometimes we make inputs, you know, when we check and we realize that certain areas are missing, we make inputs. But I must say that so far, it's been good in terms of even the awareness level compared to some years ago. Okay, and like the quality officer said, now we have a lot. Now people are aware that we need to have protocol in everything that we do, and so they have produced. Now the education aspect, if you heard my presentation, that's the area that is more important. And in that direction, the compliance department alone cannot do it, because some of the protocols are technical, and so they should be disseminated at their level, you know, at the level where the people are working. And that is why we bring on board the heads of units and the heads of departments to also come on board. And if you have also realized, at meetings, I try teasing out certain things that we need to revisit, we need to educate our people on. So yes, we are doing our bit, but we will need the support of the people on the ground, especially the heads of units.
Okay, thank you very much. So I believe that we've gained a lot of insights from these, my panelists, from administration to health informatics to compliance to Mr. Pra says we are doing well, so we have to continue to do well. It's a journey, and it's like you're sitting in a plane. It's halfway, you can't tell the pilot that you want to get down and go. You have to continue to move. So once we've sat in the plane and the plane is in the air, we don't have an option but to eat the food that they bring us in the plane and then sleep small and watch videos small, but we are in the plane. So we are in this quality journey together, and we have to continue to work hard and improve our processes so that next time Safe Care comes, we'll not be at level 3, but we'll get to level 5, and then they would actually go and say that this is one of the first facilities they've been to that moved straight from level 3 to level 5. So, Mary, like you said, people will have questions from their presentations. So I think it's time for us to take their questions. So you will sit here and then you would answer the questions as they come.
Question, please show your hand. Oh, wow.
Okay, thank you. So, my question goes to Mr. Pepper. Please,
Please, your name and your department.
oh, sorry. I'm Margaret Tutu. I'm at Adenta, Lesson Department. So, some of us have guidelines and things. There are some requirements that you can't find from the department, or you don't find one for everyone. So you need to come up with one that suits your unit. Is that a problem when they come and maybe Sakumono has one different from Adenta, or it's different from the main? Because maybe we don't have one for TTH. So we are trying to develop one that fits our unit. I don't know your take on that, please.
Okay, I think it's a good question. So let me go a little bit into Safe Care. So Safe Care, they do for facility per facility. Okay. But we are a company. And then we want the standard which is in Adenta to be the same standard when you go to Sakumono. We don't want varying standards. It's like KFC, the recipe that they have all over the world is the same. That is what we want to adopt. So if you have a guideline and you think it's working perfectly for you, escalate it, send it to your nurse in charge. Okay, I think definitely to get to DNMS. Then now we will look at it, then standardize that one for all the facilities. Unless the service that you are providing there is peculiar to only your facility. That one, you can develop maybe a guideline or an SOP. But even that, the DNMS has to still approve it. Then now it becomes formal. Are we together?
Sorry, because we were supposed to have come around. They were supposed to have come around, let's say, on Wednesday or so. And some of the things we were already doing them, and we had the guidelines already. So it means that after the guideline, I should have brought it to my facility, my departmental head to endorse before maybe we're supposed to upload.
Yeah, exactly.
Yes, please. Even though it's not a protocol, it's just guideline for us at the unit.
Yeah, so it has to go to your head of department. The head of department will approve it, even if it's, like I said, it's peculiar to your place, before you can upload it. And then I also discourage people or facilities to upload things which have not been approved by the head of department. In that we are trying to put security features on every document that we put on Safe Care, because it's a third-party platform. So we try to put some features on it before we upload them. So please, maybe you have to send it to your head of department. Let it be certified before you upload it. Okay.
Okay, next question. I think I saw a hand.
Thank you very much. It's been an insightful presentation from all parties. My name is Frederick Adu. I'm a duty manager. I would like to know from the panel, before we began our quality journey, where were we and where are we in terms of our clientele levels and our profitability as a company? And now, after all the input, all the trainings into our quality journey, where are we? What are the positivity in our quality journey? Thank you.
Thank you very much, Mr. Repra. I think you would.
Okay, so there are a lot of positives. Okay, so before we started the quality journey, for me, nothing existed. I know we used to have a quality team way back, yeah, but then it wasn't very functional. Okay, and then in Bright's presentation, I think Bright talked about structures, then processes and outcomes. So for you to start the quality journey, you need to put in the structures. That one is even a big boost for us as a company. So now you put in the structures, then now we are at the level of the processes, okay? So we are trying to put in the processes, we are trying to develop our SOP policies and so on. So that is the level of, that's where we are in terms of processes, which for me, I also think that is a good thing. Now we are looking at outcomes. When you draw an improvement curve, it will first dip first. It will go to the lowest ebb, just like change behavior. If you want to change behavior. Because now you are starting something. Now, for example, let me give you an example. For example, if you take things like maybe incidents, at first they were happening, but people were not recording. So now, if you draw the curve, because people were not recording, but now they are recording, if you draw the curve, it will dip, or it will be very bad. You see it to be very bad. Maybe for every month, you're having maybe like 100 of them when it comes to incidents. You might think that, your system is bad. It's not because your system is bad. There could be an improvement, but now, the mirage is that because you were not documenting it, now you cannot really compare. But I think that for the outcomes, we are doing very well. 2022 client satisfaction survey is different from 2023. And 2023, there's a lot of improvement. One thing which was fascinating when it comes to even these two surveys that we've been able to do. Yes, even in the past, we didn't do it. We didn't even take feedback from staff, even from our clients, we're not doing them. And then now we've even moved extra mile to put client feedback where you scan your QR code and then you can just enter. So even with the 2022-2023 surveys, there is an improvement of the 2022 one. And then it correlates to staff satisfaction and client satisfaction. They've all gone up. Why? It means that we are doing something better. So I think that there is a lot of improvement. The knowledge aspect, the structures aspect. Now we have a patient safety team. Because if you don't have the safety team, what are you recording? You are recording nothing. You are not conscious about your patient. They come in and then they go out. And sometimes there's a lot of deliberations when it comes to patient safety, when it comes to quality, even at management level. So for the past, I think this year or last year, getting to the end of last year to this year, every management meeting, I go to do a presentation. At first, it wasn't there. But now they want to keep track of everything that we are doing when it comes to quality. So I think that even for these structures to be put in place is a big boost when it comes to quality improvement. So I think that we are on the right course. I can't talk much about the financial aspect, but we should also understand that quality is also expensive. Quality is expensive initially. Because if you are, yes, for example, at first we did not have quality officer. Now there's a quality officer. So the quality officer has to be paid. You understand? So I think that quality in itself from the start it looks expensive. But then when it starts to yield results, it brings more revenue. Let me take an example. Let me make an example when you go to the lab. For example, the lab, if you are doing quality, maybe you might be tempted to add more people. But now you avoid a lot of mistakes. And once you are avoiding a lot of mistakes, maybe at first, one patient lab test, they were repeating maybe like 5 times. That 5 times, because now you've put in the proper measures, now you won't repeat it 5 times. Maybe just once, you are convinced because you've put in quality measures. So you won't run the test 5 times to make a lot of waste in the system. Again, even lab now, they have validation team. So validation team are staff that we have picked to be at the validation team. So now what they are doing is that, so now we are having extra staff for validation team. So now what they are doing is that every results in the system, they have to scrutinize it first. Because we don't want to give patients results and HIV is negative, we are saying it's positive. That brings a dark cloud on our image, which is also not good. Do you understand? So it's part of the quality process, but sometimes you need to invest first before you see the benefit. So I think that we are doing well. Thank you.
Okay, so in translating quality improvement to finances, you can see that there's, like he said, a reduction in waste or an improvement in efficiency in the organization, and that will definitely make us more profitable. Things like medical legal lawsuits, we are having a reduction in the number of people who are suing us because of improvements in our processes. We are taking our client feedback very seriously, and we are acting on it. It's even helping to sustain and increase our patient attendance, because people like the care that they are given. Is an improvement on what used to be. Recognition, it places the organization strategically in the healthcare space. It's helping the brand. It's helping the brand recognition, and things like all the awards we are getting, they are a result of all these quality improvement interventions. And so the next phase is the collaborations, and we can see that a lot of organizations are reaching out to collaborate with us, even sending people to be mentored. You know, all sorts of organizations are now reaching out because they are impressed with what we are doing, and they want to learn and be associated with the brand. So there are lots of positives from the quality improvement journey.
Yes, in addition to what Mr. Pepra and Madam have said, if you look at as at 2022, beginning of 2023, even our data accuracy, we have an issue with it. But then as a result of this quality improvement journey, we can now say that data accuracy currently is about 90% or more. And that is how current organogram that the hospital has drawn up. It's an aspect of the quality improvement drive. Hitherto, reporting lines from various departments was not so clear, but with the organogram, we know the reporting lines we're able to follow. Then we also have in this performance management system that we are all aware of that is guiding our performance. Then we can also talk about the client feedback that we receive. In fact, it's interesting to know that the client feedback we receive is what has given birth to the OPD renovation that we have at TTH Main. It's part of the quality improvement drive that led us to collecting feedback from clients, and which has led to this OPD renovation. So the benefits are numerous. We cannot count all of them at a sitting, but they are there. If we want to identify them, we'll be able to pull so many of them.
Okay, so any other
Okay,
question?
so, sorry. In addition to all that they've said, you see, sometimes it's difficult to isolate only the quality aspect of it. A lot of things are going on, and they are all in line with the quality. Talk about risk management, talk about patient safety, and all those things. They are all aligned. And I'm glad the question is coming from you, because you see, the quality journey has put in place that duty manager position. You all know, you are a duty manager, so you realize that the kind of problems you are even solving at the client's level. That's why I was coming to say it when the CEO said the legal issues have now gone down. And we know the work you are doing there. Every day you bring reports for night shift, day shift. We get to know the issues quickly, we tackle them, and all these things are part of the entire quality process. You know, so it's a process. And like others have said, you may not see the full benefits now, but once we journey along, the benefits will be coming. Yes, the benefits will be coming. And for me, even with the financial side, we've not sat down to calculate. Yes, we've not sat down to calculate. And if we should, we'll be able to establish a trend, you know, that can be linked to the quality journey. Yeah. Thank you.
Thank you very much.
Madam Chair, I think that the quality agenda also brought a few changes in the medical department. You realize that on the ward, TTH, we used to have only ward rounds on Thursdays, where the patient gets to engage the physician specialist. Now we do almost 5 days in a week. The physician specialist comes on ward rounds, even including weekends. And so that has gone a long way to improve the quality of care, to the extent that people in other hospitals are forcing them to refer them to Trust Hospital. We also have changes on the special.
We'll look at that after this meeting. No, we'll look after that after this meeting. I know where she's coming from. And so surgical unit has been you have been treated super fairly by the office of the because you requested for doctors. You looked through, picked the best, and requested that it be given to you, to the disadvantage of all others. And because you are very close to Dr. Fosu, without even telling me, he granted your request. he granted your request speedily. So when others were requesting for same, they were gone because the surgical unit had captured them all. So thankfully, it gave you peace of mind to put together 20 good protocols. If your doctors were worried,
they need to be able to enhance.
Informatics unit is the baby of also quality improvement. Informatics unit, as we were told, came up as a result of quality improvement. All right, so in all what we do is all part of the quality improvement. It's all part of where we've got into. I just want to put across that Like I indicated in the last part of my presentation that we want to get to a level 5 and even beyond. What we need to be able to get there with respect to data is to build up systems that will prioritize data collection, data analysis, data interpretation, and then which will inform data-led actions. And this will be done by us all. It cannot be done by the upper level. It has to trickle down from up to the unit level. And so the quality journey is for us all. It's everybody's business. Thank you.
Thank you. Mr. Susu, last words.
Yeah, for my last words, I will talk about communication and collaboration. The hospital administration and support service thrives on communication and collaboration to provide quality. So everybody needs to be on board. If you see something, you have to say something like they say. So whatever you see that is affecting quality in your unit, in your department, at your facility, as far as it is creating a gap, please, let's communicate it. Let's talk to the appropriate quarters, and then we find a way to bridge that gap so that we can improve quality.
Thank you. So, so far so good. We've journeyed well in terms of the quality process. What I would say is that let's keep learning. Get to know what is around you that you need to comply with. But one area that I will passionately appeal to all of us and everybody listening to us is an area we are not doing well at all, that we need to do something about it. Our data protection is very poor. The data, you are handling patients' data. Please make sure you ensure confidentiality. Don't be giving your user ID out, your password out for somebody to use to go in there and see somebody's details. Don't just open your Health Pro and leave it there for people to come and scroll through to see other people's data. Let's work around that. Data protection will be visiting us very soon. And when they come and they see some of these things, it will not be good for our image. Thank you.
Thank you very much. So like I was saying, where the world is going, if we decide as a facility to sit down and not get abreast with quality, would be left behind. And when I sit in the consulting room and then I advise people about lifestyle changes concerning their disease conditions, typical example being cholesterol. They do all that, they see the dietitian, they follow the exercise, but when they come, sometimes they are not at target, and then they go like, oh, so after all this, I'm still not at target. And I tell them that if you were not doing all this, you'll be worse than what you are getting now.
presentations from the various and every facility. So we give you opportunity, you show us in terms of quality the things that you've been able to do. For example, maybe you saw a gap or a gap was identified by SafeCare and then you've been able to address it. We want to all know all those things because we have to also tell our success stories and encourage ourselves so that we can move forward. So I'm pleading with you that all of us should join. When you go back, send a message. Let's all come together so that we can move forward. Thank you.
So unofficially, I bring the microphone to Madame to give us an announcement.
I have several things to say.
much for spending your time with us, taking time off your schedules. I know most of us were selected to attend, but you could have said no. You could have said you had other things to do, so you wouldn't come. So thank you so much for coming. We hope to see you at the next event. As Mr. Pepra mentioned, I think that is on Wednesday. That's 20th, between 20th to 22nd. And then for some of us, we would get to meet you on the 26th for the Client Engagement Day. As we all know, we have a memorial service coming up on the 21st at Premium Center at 2 p.m. So let's all do well to gather there to commemorate and have a service for our sister Tabitha. And then on the 23rd, we will gather to attend her funeral as well at Dobro in Sawum. Apart from that, I think that is that for the time being. So please, let's stand to our feet. I take the microphone to Mr. Sosu because I like the way he prays. And so he's going to share a closing prayer with us. It has to be powerful, just like the beginning, the prayer that we had in the beginning.
Shall we pray? We humble ourselves before you, our Creator, the source of our lives and the sustainer of it. We began with you this morning and we are ending with you. We thank you so much for your blessings being on this program all throughout. The lessons that we have taken to heart, help us to also put them into practice so that in the end, as we achieve successes for the work that we do, we will also give the praise, the glory, and the honor to you and your only begotten Son, Jesus Christ. Please forgive us also of our shortcomings and our sins against you, and help us to always have a good relationship with you forever and ever. In Jesus' name, amen.
Thank you so much. So the last thing is we are going to take photographs. Are we off? We are going to take photographs.